Roughly 17% of American adults will meet the criteria for a substance use disorder at some point in their lifetime. Historically, substance dependence was broadly categorized as a moral failing or a deficit of character. That classification is biologically inaccurate and actively impedes effective treatment. Substance use disorder is a quantifiable medical pathology. It is defined by specific physiological and behavioral adaptations that occur in the brain and body over time. Effectively managing a condition of this scale relies on a rigorous end-to-end clinical pipeline. This pipeline operates in 3 stages: establishing objective diagnostic criteria, deploying multimodal intervention frameworks, and executing logistical statewide delivery. Effectively treating SUD requires systematically replacing moral judgment with an integrated clinical and logistical system. Modern clinical psychiatry establishes its objective baseline for SUD using the DSM-5 framework. A diagnosis requires consistent symptoms to present within a strict 12-month window. The framework relies on 11 specific diagnostic criteria, tracking behavioral, social, and physiological changes. The matrix categorizes data into 3 clusters. First, loss of control, tracking excess usage and failed attempts to quit. Second, social and functional impairment, measuring cravings and abandoned activities. Third, physiological and risky use, isolating hazardous use, tolerance, and withdrawal. These criteria successfully translate the chaotic, highly subjective experience of addiction into distinct, measurable clinical data points. An SUD diagnosis relies on aggregate thresholds. The total number of criteria met dictates the diagnosis, rather than the isolated intensity of any single symptom. Looking at the severity meter, exactly 2 to 3 criteria dictates a mild diagnosis. Meeting 4 to 5 criteria elevates the diagnosis to moderate. Finally, 6 or more criteria met crosses the threshold into a severe diagnosis. This mathematical grading system dictates the necessary intensity of the intervention. It removes guesswork from the clinical intake process entirely. Once diagnosed, high-efficacy recovery relies on a multimodal, dual-vector treatment approach. Single-modality treatments, relying exclusively on either therapy or medication in isolation, frequently yield suboptimal clinical outcomes. This architectural model illustrates the matrix. The first pillar is behavioral intervention. The foundation consists of specific frameworks, motivational interviewing, and cognitive behavioral therapy. These are structurally reinforced by contingency management and 12-step facilitation. These behavioral therapies modify a patient's coping mechanisms. However, they frequently require biological stabilization to take permanent root. The second pillar is pharmacotherapy. This is deployed when biologically indicated to support the ongoing behavioral work. These medications act directly on the brain, stabilizing neural pathways that have been disrupted by prolonged substance dependence. Specific pairings are deployed based on dependency. Buprenorphine stabilizes opioid receptors. Naltrexone manages both alcohol and opioid pathways, while nicotine replacement therapy manages tobacco dependence. Crucially, the highest recovery rates occur when behavioral therapy and pharmacotherapy actively combine. Treating neurobiological symptoms alongside behavioral symptoms is the non-negotiable modern standard of care. Clinical efficacy is entirely irrelevant if patients face geographic or financial barriers to accessing it. In Georgia, Coping and Healing Counseling, CHC, addresses these systemic deployment issues through a specific logistical model. As this map of Georgia illustrates, their 100% HIPAA-compliant telehealth infrastructure serves all 159 counties, eliminating geographic isolation entirely. This network is powered by a diverse, culturally competent clinical workforce of over 15 licensed therapists, including clinical social workers and professional counselors. To remove access friction, specific financial engineering is required. As this dashboard interface shows, their direct integration with Medicaid results in a $0 patient copay. Commercial insurance plans, including Aetna, Cigna, and Blue Cross Blue Shield, are capped at an accessible $0 to $40 per session. By combining a robust telehealth infrastructure with strategic insurance integration, the CHC model functions as a proof of concept for neutralizing the historical barriers to SUD treatment. The delivery mechanism must support the full clinical standard, requiring a telehealth network capable of facilitating multimodal care. Coping and Healing Counseling utilizes an active care coordination protocol. As these flow lines illustrate, their remote behavioral therapists are explicitly linked with a patient's local prescribing physicians. This coordination guarantees that the behavioral therapy interventions accurately align with the necessary pharmacotherapy. Closing the communication loop between remote clinicians and local prescribers is the vital final step in architecting a successful intervention. Modern SUD management systematically replaces moral judgment with precision diagnosis, multimodal treatment, and frictionless logistical delivery. Platforms like coping and healing counseling demonstrate that evidence-based recovery can be successfully deployed at a statewide scale. For clinicians and administrators seeking to route patients and initiate care coordination, access the Coping and Healing Counseling portal at chctherapy.com or call 404-832-0102. The clinical tools for recovery already exist. The mandate now is executing the